Hi, everybody. Thanks so much for being here. I'm Dr. Sandra Demars. I'm a hospitalist at the VA, and I will let our expert consultant introduce himself.
Hi, everyone. My name is Fertrin. I'm one of the hematologists at the Fred Hutch. I also am the director for the Sickle Cell Disease and Iron Overload program. So if you ever have any questions in that field, feel free to reach out.
Perfect. We were just commenting on how we don't have as many sickle cell patients as maybe other places that people train in the country. So that's wonderful. Excellent. Well, thanks everybody for being here. While we get set up with the presentation, I just want to make sure that every group has someone assigned to kind of be our go-to to respond in terms of kind of answers that you guys were guessing or what your discussion was within your group. So otherwise, we're just waiting for the presentation.
Yeah, thanks. Just one more second here. Appreciate everyone's patience. Let's see here. It's just taking.
Thanks everybody for being here.
Okay.
For our hematology review session. So for the first question, you guys should have already read through it, talked about it, hopefully looked at the questions. For summary, this is a 55-year-old gentleman who's lost consciousness. He has a large subdural and he's got an INR of 3 and he's on warfarin. So in the emergency department, I'm assuming they gave vitamin K and they need to go to emergent neurosurgery. So do folks, we could poll, I guess, all the rooms, the breakout rooms of what answers you guys came up with and just kind of see how that spread was. I guess I get to vote too.
So do I.
Let's see what we see. Oh, good. So we've got an even split for B and C, and a small group for A. Does someone, since C is the second choice of the 2 most popular, does someone from a group that voted for C want to tell us why that's what you thought your answer was? Or why that's what you chose? Don't be shy. Half the group guessed it.
Our group was a little bit split between B and C. We wanted to replace vitamin K dependent factors. I think some of us were feeling that C over B just because we'd never used factor 4 prothrombin complex in practice.
Totally. That's a good reason. Anybody for B want to tell us why you chose PCC?
We said B because I think 4-factor PCC has a little bit more reliability and works faster than FFP, but unfortunately a lot of institutions don't have PCC, but if it's available, we thought that we should go for that due to the increased reliability. And because it's a more emergent situation.
Got it. Okay. Does anybody want to talk about A, that voted for A?
I think it was literally one person. So.
Okay, all right. We'll just move on then. You can go to the next screen.
Oh,
sorry. You put up the wrong one.
Okay.
That's okay. It was in the second email. It's the one with answers.
Okay.
But that's okay. We
while you're talking, I will pull that up.
Okay, so the answer was B. And the answer is B is because it acts faster and it's a smaller volume. Dr. Fertrin, do you want to talk about it a little bit while we're trying to pull that up?
Yeah, absolutely. I think first, FFP is not a wrong answer. It's just not the best answer. I think in the past, and especially and you're right, I think Adam mentioned that, if you don't have PCC, fresh frozen plasma works beautifully. It's just a matter of volume, and you need to thaw it. There are some complexities to using fresh frozen plasma. Also complications, you're more likely to have allergic reactions with FFP. So there are things that there are reasons why PCC is really chosen as a better option to reverse patients on warfarin, especially when it's emergently. I think first thing, I'm glad no one picked D, because that's that's supposed to antagonize a specific blood thinner, the dabigatran, not warfarin. So that's a good thing. And cryo would not give you everything that you need to be able to safely operate on this person's brain. So again, there's nothing terribly wrong about FFP, but if you do have PCC, that's the one you should pick. The one thing about PCC that people have to be extra aware is the risk of clotting. So it is very, very important to know if the patient has a recent history of clotting or HIT. Those patients are more prone to have a clotting complication. Of course, if someone needs neurosurgery, then you'll have to weigh the risks and benefits. But it's definitely something we would probably contraindicate PCC in someone who is having an active clot. Let's say they had just had a PE and had started anticoagulation. They wouldn't be on warfarin. So I think that's unlikely to happen. But just so everyone is very aware, it is the most dreaded complication.
Thank you. Does anybody have any questions on that?
And the risk of clotting, does it happen within hours, days? What is the timeline when you give someone PCC to reverse
You would
warfarin?
expect it in hours because it will wear off also. So if you're prone to clotting, you would be feeding the clot on the spot. So you would expect a clotting complication pretty quickly if you ever have that.
Excellent. Oh, John, we can't hear you if you were talking. Okay.
I just want to make sure you're able to see the updated screen. Okay.
Perfect. Thanks. So yeah, I think we covered most things on this slide.
Last quick comment, just so everyone is aware. If you give someone vitamin K IV, you will get good production of factors within 6 hours or so. So it really is meant for emergent situations. Otherwise, there's if you're going to, it's not so emergent and you're going to wait a few hours, there's a chance you're going to correct that INR. Please keep in mind that if you overdo the vitamin K, you will have a hard time getting the patient back on anticoagulation after the surgery. So that's also another problem.
Okay, thank you. I think we could probably go to the next slide. I think we covered most things on here in the interest of time. Great. So next question. Again, I believe you guys all read the question, so I'm not going to read all the details, but 24-year-old who is homozygous for hemoglobin S, who is on folate and hydroxyurea, who is febrile, tachycardic, tachypnic, hypoxic, looks ill, has a murmur, has crackles. Initial hemoglobin is 7.8, has a leukocytosis, has bilateral infiltrates, gets fluids, gets low molecular weight heparin, ceftriaxone, levaquin, and then worsens 6 hours later. So we can poll the group, show us what your groups thought about what would be the next thing to do: a CTA, exchange transfusion, amphotericin, heparin, or an ultrasound.
It looks like there's still a few votes trickling in. Give a second here. Okay.
B, everyone got B except for a couple, but mostly B. Excellent. So Before we talk specifically about why that is your answer, I think the next slide, if you would, John. So does somebody want to talk about what's going on? Why is this patient decompensating? Anybody?
Don't be shy. I heard a lot of people talking about it in the small groups.
Right. I mean, like 92% says B, so they must have thought there was a reason to do that.
Yeah, so we talked about this patient maybe having acute chest syndrome, and if the initial treatment is not working out for him, then we need to move to next line, and it is exchange transfusion. So that was our answer.
Great. Yeah, we can go to the next slide. Perfect. So yeah, acute chest syndrome, one of the most common complications of sickle cell disease, one of the most common causes of death. May occur secondary to infection, embolism, fat or bone, in situ thrombosis, or a combination. And so the clinical characteristics are exactly what we saw in this patient. So we can go to the next slide. And so, yep, exchange transfusion. So the treatments are oxygen and centrifugal pain control, of course, antibiotics, and yeah, goal hemoglobin of 10. And so depending on the severity, determines whether simple or exchange transfusion is recommended. And I'll just let Dr. Fertrin, I think, take it from there to talk further.
Yeah, so I'll highlight that it's a syndrome, so you don't always get all the the details the way we get in this very typical situation. Also, determining whether it's mild, moderate, or severe is quite difficult. When the patient is intubated, of course, it's severe, but otherwise, it's not as straightforward. There is no score for this classification. And keep in mind that I can't really tell if the patient has pneumonia or acute chest. We'll always assume there might be an infection, but for adults, it's mostly not infectious. We see a lot more acute chest with infection in children. So for adults, it's pretty common that patients get CT'd for PE. So I understand why the options included that. Unfortunately, if you already have the infiltrates and everything else, even though it might be a lung infarct, unlikely with the presentation, but still, it's not wrong to CT the patient. But if they're that severe, the priority is to exchange. Same thing for all the other options. It was mostly looking at a differential with PE or with like fungal infection or something along those lines. So those differentials are important, but if the patient is crashing this badly, the first thing you do is exchange, because whatever is causing the acute chest, the sickling to the lungs will be very severe.
Thanks. Does anyone have any questions about that?
So for severe acute chest requiring intubation, is it just like basic normal ARDS management on top of that?
Yes, you will do all those things. You just add the exchange transfusions on top of that. By the way, even if the patient has a very high hemoglobin, even if you're having only moderate, let's say the patient is on oxygen but not intubated or something like that, you might still exchange the patient rather than do simple transfusion. Simple transfusion is only an option if you have enough room to give patient blood. Otherwise, you're better off just exchanging. The patient is super low on a hemoglobin. Let's say the hemoglobin were in 7.8 or 5. You could still probably exchange the patient, but then it will be easier to, in the end of the exchange, to correct their hematocrit to whatever your goal is. Let's say it's 28, 30.
Thank you.
And when do you expect to see improvement after you do the exchange transfusion?
That's a $1 million question. Thanks for that. Unfortunately, in my experience, it takes about 72 hours for things to turn around, which is why we really have to pull the trigger early. Most patients they might stabilize a little, but usually it's like 48, 20 to 72 hours, especially if they go on pressors. You can see that they get off pressors after a couple of days, but it takes a while.
Thanks. We got a question. Should any medications be avoided in that period?
Nothing in particular. Patients can still be managed. Well, if they're intubated, they're sedated, so pain management is a little easier for that matter, but there's nothing in particular that you should be avoiding. I think just keep in mind that adults with sickle cell disease might have some degree of heart failure, some degree of pulmonary hypertension, especially acutely with acute chest, and some degree of kidney dysfunction. So we have to be mindful of the fluids that are going in.
Why do all these patients have a murmur is the next question.
Great question. Typically, because of the anemia, especially if they're having an acute complication, you might get that murmur be more prominent, but it's not a requirement. It's just very common.
All right. Great. I think we can go on to the next slide. All right, so this is another patient with sickle cell who was seen 1 week after hospitalization, has not had any previous pulmonary or major complications, typically has 2 to 3 episodes a year, kind of has returned to baseline. He's only on folate. And these are his labs, hemoglobin of 8.4. And our question is, what do we do next for this patient? Folate, hydroxyurea, and central spirometry, monthly exchange, monthly simple transfusions. What does the group think?
All right, this seems pretty unanimous here.
Amazing, excellent, hydroxyurea. That is correct. We can go to the next slide. Okay, so I think Dr. Fertrin, I can just let you talk about what hydroxyurea does and why we choose to treat our patients with that, if you would.
Yeah, so patients with a history of severe acute chest, or patients who are having 3 or more admissions for vaso-occlusive crisis, those are the patients who very typically have an indication for hydroxyurea. I think, of course, over time, we've expanded a lot the indication for hydroxyurea because it does a lot of things. It will reduce the number of white cells and platelets. We now recognize that these cells are part of the vaso-occlusive process. It will, of course, induce fetal hemoglobin. Fetal hemoglobin has several beneficial effects on sickle cell disease. So it will not participate in the polymer formation. It also has a higher affinity for oxygen. So hopefully overall increasing the oxygen content of the red cell, which would destabilize the deoxygenated hemoglobin S. So reducing sickle hemoglobin. It's also a nitric oxide donor, and we know free hemoglobin due to hemolysis decreases nitric oxide. So it does a lot of different things. And we recognize that it not only decreases the frequency of crisis, decreases the chances of acute chest, also decreases need for transfusions. And now more recently, there are papers also showing a smaller instance of heart disease long-term. Overall, it's been indicated almost to any patient who is a homozygote for sickle cell after age 6 months. So it's been very widely used. For a patient like this who has never been treated with anything, hydroxyurea would be very high on the list. Looking at other medications that have been approved by the FDA, there are other options. There are, I think, along the same line, at least in terms of effect to decrease acute vaso-occlusive crisis. The crizanlizumab infusions would be another option, but still they are considered sort of second line. You always try hydroxyurea first. As far as the other options go, yeah, there's really no need to go up on the folic acid. Keeping in mind that patients with sickle cell disease at baseline might have a mild macrocytosis due to the reticulocytes. And if they are on hydroxyurea later, hydroxyurea will cause severe macrocytosis, but we should never mistake that for folic acid deficiency. And incentive spirometry might be helpful during the acute phase. Exchanges and simple transfusions are not standard. but we do use on occasion monthly exchanges for patients who are refractory to other medications.
Oh, I got a question here. I've seen hydroxyurea used in leukostasis. Is the mechanism different in that case?
Somewhat different. We use hydroxyurea in those cases to decrease the number of cells more rapidly, but it will take a few days. So if the patient is in leukostasis, you can start them on hydroxyurea, but they will probably need leukapheresis regardless. So it's a little different. You won't be able to wait for any other long-term effects. Fetal hemoglobin induction specifically takes a long time to happen. So it wouldn't be that important for sickle cell disease, for leukemia patients with leukostasis, but yeah, it would take longer.
I have a question. If patient was on hydroxyurea before having the severe acute chest syndrome, then would you put him back on hydroxyurea or consider a different treatment option?
So first, we wouldn't stop hydroxyurea during an acute event if we can. So that's definitely something to keep in mind. And if they are failing hydroxyurea like that, first you want to make sure they are at the optimized dose, and you could add other medications. So L-glutamine or crizanlizumab infusions would also decrease vaso-occlusive crisis and could be added to the patient's treatment.
Great. Thanks. Does anybody else have any questions? Any more questions? Excellent. All right, we can move on then. Okay, this is a 32-year-old pre-op for a hip replacement. He also has sickle cell disease, 3 to 4 hospitalizations per year. He's on ibuprofen, hydroxyurea, and folic acid, and his pre-op hemoglobin is 5.8. So what do we want to do as our medicine consultants? You guys want to vote for, yeah, so exchange transfusion to 30%, exchange transfusion to 50%, simple transfusion to 10, simple to 12, or no transfusion. So not currently in crisis, but it's just anemic, basically.
Still have a few answers trickling in here.
A lot of folks for C, simple transfusion to 10, but we've got some for A and B for the percentage exchange transfusion. Does somebody from A or B who chose those percentages want to talk about why you chose those answers? Or someone from C could talk as well.
I think our group's reasoning for C was that exchange transfusion was kind of limited to those acute situations. And so we just wanted to transfuse to a goal of 10.
Got it. Anybody else have any comments on what conversation happened in your group?
I guess just going to this question, I think it's a very hematological question to know the specific answer, specific like number cutoff, but I think it can be like an answer of exclusion, because like it seems like exchange transfusion is going to be like a whole thing, and I'm not sure if they will need it for like every surgery. If they're not in crisis, then we can, you know, rule out the A and B, and then D seems like a very high cutoff and no transfusion, they're already below the 7, you know, cutoff, then maybe C would be the answer. But like knowing this right off as an internist, I feel like we won't know it.
Fair, very fair, good. Yep, lots of multiple choice testing experience in this group. Okay, yep, we can move on to the next slide. And the answer is C, simple transfusion to 10. And yeah, it looks like there's definitely been some studies about this and some data to support this in terms of patients that require intubation or kind of low to moderate risk surgeries to have that goal of simple transfusion of 10. but I can let Dr. Fertrin speak more to that.
Right, and I like the question in the chat, by the way, so I'll get to that. But yeah, it's all about the risk of the surgery, and we're talking about the risk of having a vaso-occlusive crisis after surgery, right? So hip replacements are among like the moderate risk surgeries. High risk surgeries would be like cardiac bypass or something like that. And for a patient undergoing cardiac bypass, we would still consider rectal exchange rather than simple transfusion. I think for this patient in particular, the hemoglobin is extremely low. So just by getting the patient up to 10, there's a chance we're going to decrease their hemoglobin S to maybe 45%. But still, if it's cardiac bypass, neurosurgery, something major, you might still exchange this patient to get a hemoglobin S below 30%. That would be a very exceptional. So there is a study showing that patients will have fewer complications at a hemoglobin of 10. So we'll do simple transfusion. That's enough to give them enough oxygenation and to dilute the hemoglobin S. 12 is definitely too much. You're running the risk of causing a vaso-occlusive crisis just because of blood viscosity, even though you're giving them a lot of hemoglobin A. And I guess the problem with the ton of volume, you're right. For a patient at a hemoglobin of 5, you will need maybe 4 units. So there's a chance that you want to transfuse this patient over a few days before surgery. For planned surgery, I like patients to start getting their transfusions that week. And maybe like when they get admitted, you check it again and see if they're still above 10. And then you can always give them another unit right before surgery. And then that should be okay. But within 1, maybe 2 weeks is still acceptable if it's really hard for the patient to get transfused. But ideally, we want to transfuse them like during the week leading to surgery. That makes it for them to tolerate better, like all that volume. Yeah. And I like that comment. Yeah, you never trust that it's only 50 cc's of blood loss. That's also true. It all depends, I guess. And especially, I think, for the bone density, like the issues that we have sometimes in sickle cell disease, I think surgeons sometimes are surprised by operating on someone this young and finding it more difficult. So. Another couple of things perioperatively that I like people to know is that don't underestimate the value of hydration. Patients are left fasting for many, many hours and then they dehydrate. These patients don't concentrate their urine normally. So the urine will always look normal, clear, but because they can't concentrate and they'll lose a lot of water. So if they're fasting for too long, you need to keep them on an IV. And also cold, like cold exposure in the OR, like very bad situation for the patient. They will get into a crisis if left in the cold for too long.
Good to know. Thank you. Anybody else have any other last questions or comments on this question or perioperative management of sickle cell patients? All right, I guess we can move on then. All right, this question is a 64-year-old female being evaluated for ecchymoses, bleeding gums, and hematoma in her thigh. She has CLL. She's been asymptomatic, no previous bleeding issues, no family history of bleeding issues. She's not on any medications. Her exam is most notable for the ecchymoses as well as some lymphadenopathy. And her labs show this PTT of 88, PTT with a mixing study of 64, hemoglobin of 10.8, white count of 65, platelets of 215, and 1% factor 8 PT in a PT of 11. So what did you guys pick in terms of what you think is we're going to do next? Activated factor 7, cryo, desmopressin, or FFP? I did read it. I can't do anything about it right now.
All right, waiting for a few more answers to come in.
I can always tell when groups didn't get to some of the later questions because there's a lot more hesitation.
Yeah, and it's totally fair for everyone to vote their own answers if you did discuss it in group, or if you disagreed with your group's overall, answer, whatever. Oh, good. We had quite the spread. So it looks like B and D are tied. So that's cryo and FFP. And then it's pretty even between A and C. So I think we can go to the next slide. So I don't know if this helps anyone. I don't know if you guys knew off the top of your head what your normal values were or not, but I thought I would plug those in for some help, for some reference, because I thought it was interesting they didn't give it to you. So does anybody from your groups in your discussion, I mean, obviously the answers are all spread, so there must have been quite, I would imagine, quite a discussion about this question. Does anyone want to comment on what these labs are showing us, or what we think about these labs, how to interpret these labs? How did it help you get to your answer?
Our group talked about, we didn't know the normal values, but it looked like it corrected somewhat the PTT with the mixing study to suggest that there was a factor deficiency.
I could quickly comment how I would read through them. It's not necessarily right though. So I would think of the PTT for like most factors. I would think of the PT for factor 10, 9, 7, and 2. And it's not prolonged. So I would think this is not where like the deficiency is. And then looking back at the PTT, then there's something going on with the factors, either an inhibitor or deficiency. And then when they did the mixing study, which basically my understanding is they basically correlate for all the factors, it's still high, then I would think maybe there's an inhibitor that's causing the deficiency, and then it seems like factor 10 is lower. I did not know like what's the right percentage. Then maybe this is what's actually deficient, but that's as far as I can read through them, and I could be wrong.
Yeah, it's a complicated one for sure. Anybody else want to say anything else about your thoughts or your conversations?
Our group. Another thing to add. Oh, go ahead.
Oh, go ahead.
With this, I didn't know like the values of like especially the factor 8 activity, but after looking at that value, I'm thinking that because the factor 8 activity is so low, the issue has to be upstream of factor 8, and so I'm wondering if factor 7 is maybe correct, or giving factor 7 would correct the abnormality, because it would both fix the PTT and then would also improve downstream factor 8 activity.
Yeah, all great thoughts in terms of interpreting this for sure. I think we can go, well, I guess Dr. Fertrin, yeah, so yeah, I guess, yeah, we can either, Dr. Fertrin, if you want to jump in and say something at this slide, or the next slide, I have kind of a little bit of an interpretation of this. So, I mean, I guess we can go to the next slide and then maybe you can add in your comments if you want.
Sure. Of
breaking this down.
Yeah, so first, if you don't know the values for a normal PTT and PT, you can cheat and just think about like normal hematocrit and hemoglobin levels. They're kind of close enough, so you're not going to be too far off. Like 35 for a PTT, 13 for a PT. So just so you can at least guess if you can remember. And also for coagulation factors in general, anything below 5% is probably bad. So if you don't know the reference ranges, like anything below 5 is probably not working too well. And I agree. This is the most important information here is first, the PTT is prolonged with a normal PT, and it's only partially corrected. So if you only get partial correction, something else is making it prolonged, and you think about an inhibitor. And then the other thing is the leukocytosis, right? Like with the CLL, then that's the match. Like, okay, so I have a lymphoproliferative disorder, I have a possible inhibitor. That's a known association. So that's what they were trying to convey. And then you need to figure out like how to treat this person. Yeah, and John is saying that there's a reference page, so just in case.
Yeah.
But if you're short on time,
yeah, I didn't think it was fair that they didn't give you the normal. Yeah, let's see. Somebody else was commenting. Right, what is it? The connection to CLL? So yeah, this was new to me, that this acquired hemophilia A in terms of the autoantibody factor against factor VIII is a recognized association with CLL. How do you know how common that is? Like, is it rare or is that pretty common?
The inhibitors are very rare in general. And they happen more frequently in elderly people. So that presents some challenging clinical practice, because sometimes they start with those ecchymoses that we recognize as age-related but inhibitors are very dramatic. Patients bleed a lot. It's like extensive ecchymosis, unstoppable gum bleeding, nose bleeds. So it's not something subtle by any means. If it's just like a few ecchymosis on the forearms, it's unlikely to be just an inhibitor in the first place. But then with those labs, with that history, then you do think about an inhibitor.
And then we've got a couple questions about why this couldn't be a deficiency. Why is this not von Willebrand's?
Great question. So von Willebrand factor deficiency, and that would be like type 1 or type 3. Type 3 is extremely rare. So we think type 1 von Willebrand's disease. It could also cause like the prolonged PTT and the lower factor VIII activity. It's usually, well, first, I think it's not an acquired condition. Typically, we do see acquired von Willebrand's disease, but that's in another context. We're talking about extremely high platelets that can cause that. So I think that's the reason why they're giving you like the rest of the context and the blood counts to make sure that the platelets are normal, and that we're not thinking that this patient has an overlap of von Willebrand's disease and CLL. If they had von Willebrand's disease enough to cause those changes, we would expect them to have a bleeding history, but most importantly, it would get corrected with the mixing study. If you're missing von Willebrand's factor, the mixing study will correct it.
Okay, so then you would expect your APTT to be like somewhere between that 25 to 35 range, right?
It could be even above 140. It could be like super prolonged, but it will get corrected with the mixing study.
Perfect. All right, we can go to the next slide, I think. This just breaks down. Oh, go ahead.
Oh, just a quick question about von Willebrand. So when you have factor VIII deficiency, do you always have like a von Willebrand deficiency ongoing with it because it's basically carried on factor VIII? Is this like the right information?
For type 1, that's true. They usually go together because it's a factor production problem. For von Willebrand types 2, those types are a little different because they're functional. So usually there's a discrepancy. The activity is much lower than the amount you can measure.
Okay.
All right. So just to break down the answers, we talked a bunch about actually, no, we didn't. So yeah, Dr. Fertrin, do you want to kind of comment on why the answer is A, factor 7, when we have a inhibitor to factor 8?
Yeah, so you have to be able to activate the coagulation cascade downstream of factor 8. So factor 7 will help with that because you're giving it already activated, and it will go straight to activating thrombin and generating fibrin. And the problem is you would max out the amount of factor VIII trying to fight the inhibitor, but the amount of antibody that these patients get is humongous. So it's really hard to bypass that just by giving them more factor VIII. So you need activated factor 7 is most likely to stop the bleeding at this point. The similar reason, that's why fresh frozen plasma or cryo won't work. You will never be able to give enough of those to antagonize the antibodies. And then desmopressin is there just because there's this differential with von Willebrand. So I appreciate that option being there. because you're looking at someone who has a prolonged PTT, but then recognizing that the PTT was not corrected by the mixing study will make desmopressin a poor choice to manage this patient.
Great, thanks. Any other questions or comments about this question before we move on? Oh, so this is used for acute bleeding.
Correct. Yeah. So activated factor 7 is almost exclusively used in the acute setting.
And what about long-term treatment?
Great question. We will have to immune suppress this patient to stop the antibody production. So using steroids or rituximab is pretty standard for acquired hemophilia acquired inhibitors. And then eventually there's this discussion about whether to treat the CLL because it's the underlying disorder.
Thank you. All right, I think we'll go to the next question. Okay, this one was a patient with DVT, 26-year-old, recent hospitalization for DVT, no surgery, travel, immobilization. Sister also had a DVT. So we want to know, are we going to look for some sort of clotting disorder in this patient who's young and has a sister who also had a DVT? So yeah, do people want to vote on this? When would we test, or would we test? I guess they all are testing as an option. Test now, 2 months, saved blood sample before anticoagulation, or after a year, after you've stopped the anticoagulation for 2 weeks.
That's $1 million question. It saves $1 million test.
Give a couple more seconds for folks. I still see some answers coming in.
Oh, nice. So we've got a spread on this one as well. So it looks like B in 2 months is the front runner, followed by D in 1 year after stopping anticoagulation, and then C, people liked, or test now. Does somebody from each of those kind of groups want to talk about why you chose what you did? I guess B was the most popular one. Why do we test in 2 months? Don't be shy. We're all here to learn. Or we could pick a group. I don't know. I don't know what groups people are in, and so who hasn't been the most, what groups haven't talked?
I think I've read in the past that we can't test for hypercoagulable states while people are on anticoagulation.
That's so yep. So what would your answer be then if you're saying that? Are you going for C or for D, I guess?
C.
C, okay. Before they were started on anticoagulation. Okay. Somebody else, the different, oh, go ahead.
One other thing our group talked about is ideally you don't want to test when someone's in the acute setting. So we felt like we eliminated first since they just had that clot. We felt like the question is ideal, and in an ideal world, D sounded nice to be able to have them off the medication. Since Viroxaban is an anti-10A, would that interfere if we're looking for like factor 5 Leiden or something like that? But we felt like we realistically in a clinical setting didn't think they would do that. So we settled on B as sort of an intermediary. They're outside of this acute phase. We probably wouldn't realistically hold anticoag on this patient, but if we could, we'd go with D.
Okay.
I guess one other thing too that we were wondering is if we think that like factor 5 Leiden is kind of one of the most common causes, like is that a genetic test that would not have an issue with being on anticoagulation, or could potentially test now?
Yeah, totally. Great comment. Okay, I think we could probably just go to the next slide and then break it down from the next slide, I think. So our answer was D. to get people out of that acute phase and get them off of the anticoagulation. Because if it is not a genetic issue, then you're not going to be able to get an accurate test if they are in the setting of an acute thrombosis or if they're on anticoagulation. But yes, there is some genetic testing that can happen regardless of time, but you just can't get the full testing done. Dr. Fertrin, do you want to speak to this at all? Any other comments?
Yeah, I think the problem here is that we bundle up all these tests, right? So you could probably spread them out. If first, I won't debate that this patient needs investigation, right? A young patient with family history and everything else. Some people would argue that maybe you don't need to go this far because you already have the indication for anticoagulation with a family history and an unprovoked event, and being male, he's at a higher risk of recurrence. So this is a patient that's probably going to stay on anticoagulation for life, regardless of the investigation. That's one way of looking at it. But of course, genetic counseling, other things that you might be thinking about, factor V Leiden and prothrombin mutation could be run right now. So that's good for A. Protein C and S and antithrombin are terrible during the acute phase. So it doesn't, so I wouldn't test it now. I wouldn't test it with a saved blood sample. It doesn't really matter. Ideally, yes, you want to test them later during the course of treatment. And then for antiphospholipid syndrome, it depends on what your lab uses. The antibodies can be picked up, like they could be tested on the spot. And I've done that a few times. I just test the patient for antibodies while they're in the acute phase, because either the antibodies are there or not. But for the lupus anticoagulant, it becomes a little more complicated. And that's the one test of all of these that you're looking at to stop ideally stop the rivaroxaban when it's safe enough to do so. Do I do that? Not particularly, to be honest. That's why they say ideal, because for a patient with that high risk, you might not be comfortable stopping them because of a lupus anticoagulant. I think particularly if you're able to run the antibodies for antiphospholipid syndrome, it's not going to, at this point, it's not going to change your management if the patient has a lupus anticoagulant or not, if everything else is negative. So I guess, again, ideally, yes, you want a clean sample, no anticoagulant, and no acute clot. But in practice, I think most people will test later, and maybe you'll just test them on the anticoagulant they're on. A factor X inhibitor is not going to affect many of the labs that we run. And then if they come back abnormal, then you debate whether the drug was responsible for the abnormality. If it comes back normal, then you're fine.
I think, let's see, we got a comment. I think I would have seemed to test it around 6 months. I guess that question is like, why is the patient on a year of anticoagulation then maybe?
Yeah, that's also a great question. So first, I agree. Most of the time, we think about testing around 6 months because that's when we think most patients resolve their clots and there's like reabsorption and everything else is clear. But after 1 year, any study for any disease, for any anticoagulant will show you that after the first year of anticoagulation, no matter what, if the patient had an X% risk of having a recurrence, they will have X divided by 2. So it always falls to half of the risk of recurrence. So it's the time point that we know the risk is lowest. We don't have good data for 5 years, 10 years, and I don't think anyone would wait that long. So
great, thank you. I think we only have, I don't know, maybe time for like 1 or 2 more questions. So let's move on to the next one. Okay, this is a woman with shortness of breath, chest pain. She's 25, unremarkable medical history. She's got some anxiety, no meds. She's in no apparent distress. Statting all fine, lungs are clear, no edema. Her well score is 0. She's got normal workup. So you're here in the emergency department with this young woman. What do we do next for her? A CT, a D-dimer, an echo, or nothing? And of course, these questions are in the ideal, like, what are you supposed to do? Not what do you see being done all the time?
That's true.
It's hard, right? We do what we see, right?
Are you saying that it would be all the above?
Yeah, right. I mean, that's right. That's what happens. But great. So we do have a breakdown though between B and D. I like that not everyone said the same thing. So does somebody from the B group want to talk about the use of D-dimer in this patient? Come on. You could just be the voice box for your group.
I'm happy to tell you why I wouldn't choose B.
Okay.
Because the PERC score is negative. And so if the PERC score is negative, then we wouldn't go to Wells, and the Wells score is negative either way. So I chose D to not do what we see being done, but to choose what the what we really should be doing. So
sure. I've got a comment. D-dimer is simple. One blood test, better safe than sorry. So I got it. Okay. Appreciate that. We got voices from both sides. We can go to the next slide, I think. So the answer is D, and they did talk here about the PERC score to rule out PE. So age less than 50, heart rate, oxygen sat, no estrogen, which is important for women that age, right? A lot of people are on birth control. No previous clots, nothing on exam, and no recent risk factors. So your low test probability using Wells, which we've already commented, she was 0 as well, and a negative PERC. So that means none of those things come up, not one of them. Then no additional testing. If they have intermediate, so any of those coming up as number 1, then you go to D-dimer next. Or in high probability, you just go straight to that CTA and don't even bother with the D-dimer. Dr. Fertrin, do you want to speak more about that?
Yeah, I think most of the time people order D-dimers in excess because they're afraid they're going to miss something. But having a high D-dimer is not going to tell you anything. If a high D-dimer is going to convince you to get a CT, then you should have gotten the CT in the first place. So just stick to the probability criteria and don't overtest. We see that a lot with patients post chemotherapy and for patients with chronic hemolytic anemias in general. They get a D-dimer, it's always high, so it's not going to be useful.
And I think about that with infection too, right? I mean, I feel like a D-dimer is going to be high in infections, so I often regret ordering the D-dimer. Yeah, right? You're stuck with it, right? Whatever lab test you get, you're stuck with having to deal with that answer.
The patient is freaking out because their D-dimer is high, and then you have no option but to run the CT that you didn't want to. So.
Right. All right. Any other questions or comments before we move on?
I have a quick question. I know we don't have time. So when would you actually check D-dimer? I feel like if it's always the wrong answer to do, why do we use it anymore?
Just for the intermediate pre-test probabilities. So it's a small fraction of patients.
Okay.
All right. We can get people that don't PERC out. Yeah. So if they have any of those positive things. So if she was on birth control, right, even at 26 or whatever, then we would get a D-dimer on her. Make sense? Okay. All right. We'll go on to the next one. Okay, this is a 39-year-old cough, dyspnea. She is pregnant, 32 weeks. She's afebrile, heart rate of 100, O2 sat of 86, breathing at a rate of 22. She has some 1+ edema bilaterally. Labs not super remarkable. Ultrasound is negative for DVT. So what do we do for this woman? All right, we got a lot of people for E, so that's our VQ scan. We got about a fifth of the group for a CTA, and we got some D-dimers and an MR pulmonary angiography. So does somebody want to tell me why their group voted for which answer?
Guessing there's a lot of people scared of what's going on in the fetus.
Right? I know. I mean, like, we don't normally take care of pregnant people, but we do get asked to consult on them every now and then, right? So this is something that certainly you could have to encounter. So it's nice to know.
We didn't get to this in our group, but tell why I picked CTA. I thought, because I know that the VQ scans are not very good at determining if somebody actually has a PE or not. And I think there's some shielding that they can do to protect the fetus. That was my reasoning.
Sure. So somebody that voted for VQ scan want to comment on that?
Exactly what John said. Babies are scary.
Okay, got it. All right. Well, we can go on to the next. I guess I don't know if the fetus can get contrast. Sure. Yeah. Okay. OB consult. So the answer is E, really, because so she's pregnant, so she is already in that elevated risk category. And the D-dimer is going to be elevated in pregnancy. The reason for the VQ over the CTA is the safety of the radiation to the fetus. And so a VQ scan, if it definitively says high probability of PE, you can trust that. If you're stuck with these like, these answers that we get that aren't more definitive, then you're right, then we're still kind of stuck, unfortunately, then getting a CTA. But the VQ scan can be gotten first. I've never successfully gotten a VQ scan. Well, sorry, they do exist, I promise, I have. But I hear what you're saying. You're not used to getting them. Okay, Dr. Fertrin, do you want to speak?
Yeah, I'd say I just highlight that VQ scans are pretty reliable in terms of excluding PE, because if you're able to see the perfusion and the whole of the lungs, then in the absence of a DVT, like you should be looking for something else, right? This patient has a very high risk of having a PE. So I'd say that if she's desatting this much, the chances are you're going to see that in the VQ scan. And then worst case scenario, let's say the VQ scan were normal, my suspicion would be so high that I would be talking to radiology and OB and saying, hey, I really think it's worth the risk of a CTA, or do we want to anticoagulate the patient empirically?
Yeah, we got a question here about are CTs and radiation contraindicated in all trimesters of pregnancy?
Yeah, as far as I know, they are. It's exceptional. Like, I think we've seen CTs for patients with superior vena cava syndrome, something very dramatic. Then, of course, it's so life-threatening to the mother that you will still do it and try to protect the fetus. But yeah, technically they are.
All right, and then I think just because the next question moves away from VTEs, I believe, I'm going to go back to a prior question that's still kind of related. The question was about obtaining D-dimers. What about D-dimer for Wells score 0 in DVT? I guess is the question if they have a positive PERC but have a Wells score of 0? Was that the question? I want to make sure I understand the question. Or Dr. Fertrin, I don't know, do you understand the question? Do you see it? It says different scenario. What about D-dimer for Wells score 0 in DVT?
Yeah, I think, well, first of all, score won't help us much to determine. And I think at least for DVT, you're most likely you're most likely to be safe if you just scan the patient. If you're thinking about a DVT, I think it's yeah, if the patient has symptoms, some edema, like most of the time we're not going to use D-dimer to not scan someone's legs. I think it's different from what we do for PE, because for the symptoms for PE are very non-specific and might be subtle. While for DVT, even if you have only like mild edema, but you think the patient has enough risk factors, you will just scan their legs. I think it's not going to be very helpful for that scenario.
Okay, great, thanks.
Sandra,
right.
we probably have to wrap up.
Okay. Oh yeah, 25. All right. Well, thanks everybody. Really appreciated having you all. It was a great discussion. And they're gonna send out or post the entire PowerPoint. So the rest of the questions are on there, but appreciate what we got
Well,
through.
if you have any questions, feel free to reach out. Sandra has my contact information. Yeah, I'm happy to help.
Thank you both so much, Dr. Demars and Dr. Fertrin. We'll
Thank
take
you.
a 5-minute break and then come back for Ken's house staff meeting. So we'll see y'all soon. Thanks again for a great session. I learned a ton. And yep, we'll have the slides uploaded to our curriculum, our academic half day curriculum folder, and can also send out the slides as well. So thank you.